give this continuation session also, because the introduction to pain was done by me for the same cohort of people. So this session I would like to keep theory to minimum. For introduction of pain, I kept a lot of theory and concepts and all, like, starting from anatomy to physiology and all that, pain assessment skills. Here I'll keep theory to minimum, and we shall discuss few cases to see what is really difficult pain. When do we have difficulty in handling pain? Many of the times, our inexperience to evaluate pain or reassess pain, or we forget to reassess pain sometimes. That is a many time root cause of difficult pain. So such things, what to tell, we forget to involve multidisciplinary team. That becomes a difficult pain many a times. So my objective for this session will be mainly stressing on review in history in pain history taking, review of medications and drug compliance. Please do remember, drug compliance is very, very important. We should check with the patient, with the attender, whether the drug has been given on time. Many times they will miss the drug dose, and we will be thinking pain is not responding to 10 mg morphine, but it will be like dose would have been missed. Or they would there was a patient who took bisacodyl regularly thinking that is morphine, and because he is passing motion every day, I don't need a laxative, madam, so I didn't take that laxative. That motion tablet you gave, no madam, that one I did not take, so he showed morphine. He thought that is a laxative, and he thought bisacodyl to be the pain tablet, and told pain matu kammiya, pain did not reduce. So now we should know that just prescribing is not enough. Following up carefully, asking the patient, which tablet did you take? How much did you take? Tell me which one, how many did you take? Who is giving the tablet? If attender is giving the tablet, take the patient, take the family person nearby and ask, show me how much of the syrup do you give? Like how a pulmonologist will see the efficacy of how they are using an MDI, because MDI needs some skill to use an inhaler, right? The same way, morphine also, compliance might be bad, or the administration might be wrong, or they would have missed a tablet. So main objective of this session is reviewing the history, reviewing the compliance, and sometimes despite that pain might be persisting, we should know to change the dose accordingly, changing from sustained release to again back to plain instant release morphine. Many a times I have seen from sustained release to instant release, I change back, patient's pain gets under control. So, or I have to add one more SOS plain tablet in the background of sustained release tablet. So we would not have been used to sustained release morphine so far, or we would have been giving 4th hourly morphine with plain morphine so far. So these kind of dose changes will definitely give some, where pain relief will be inadequate. Yes. Disease advancement should be kept in mind. The another thing is, like, there might be new nerve invasion, new bone invasion, bone mets would have been there, brain mets would have been there, spine mets, liver mets would have been there. So new advances in the disease process as such will cause some difficult pain. So we should be open-minded to stop, to think for a while, what is happening new now? Why is that same morphine which was helping so far not helping now? So this is how difficult pain, that's what I see as difficult pain. Or from the diagnosis itself, sometimes there might be difficult pain. A combination of neuropathic, neuroplastic pain and somatic pain can become a difficult pain. So and in that outset, what we have to do is we have to analyze one after the other, see how can I handle somatic part of the pain, how can I handle neuropathic part of the pain, how can I handle this nausea-plastic? Should I give some desensitization process for this patient? That part we have to think, and then not to forget the total pain again. We have to think, have I addressed the physical aspect? Is there some spiritual aspect left over? Did I not address some psychological aspect? So we have to sit with the patient to handle all these concepts. So we will go from the presentation with some small basic things again. SK, can we have the slides? So it is basically some summary of practice principles, what I personally use and encounter. Next slide, SK. So we are just revisiting the same definition again. So it is an subjective. Pain is very, very subjective. Next slide, SK. So this also we have seen already. When patient tells it is pain, it is pain. We have to assess the pain in a very methodical way. We cannot ignore when somebody is telling pain. And when somebody is not telling pain and he appears to be in pain, still we have to consider it as pain. We have to use the appropriate scale in dementia and patient on ICU or ventilators and children and people with communication disability. Okay, so this is just to revise from the previous concepts. Next slide, SK. So this was also discussed by us in the introduction of pain itself. We use multidimensional pain scales and unidimensional pain scales. Unidimensional pain scales will talk only about pain. How much is a pain? How severe is a pain? That is like phases scale. It just gives a number or a phase. Multidimensional pain scales will involve aspects, social aspects and psychological aspects and mood changes also. For example, fibromyalgia questionnaire will have questions about sleep, questions about socializing, or all these things. So DN4 questionnaire is for neuropathic pain. Last time I had shown you the DN4 questionnaire. Brief pain inventory is a one-page questionnaire. It will have some 20 questions. A body map will be drawn. I told you the significance of marking in a body map where the pain is, so that we will not miss one single pain also. We will be able to connect the dots if multiple area of locality of pain is there. So we should get adept to using these pain scales if we are seriously into the business of handling pain and palliative care. Okay, next slide, SK. This was also described last time. We can either use the PQ or RST format of taking history. Why? Because we have to, every time we have to remember asking these questions. Otherwise, we will not get the clue. We do not have advanced gadgets to find out what kind of pain this patient is having. The main thing is our clinical acumen and our communication skill only. We should be able to get the right kind of history from the patient and the family and understand what is happening with whatever gadget or scanning or radiology equipment you have. Radiating pain cannot be told by the machine. Patient only has to tell us. So we have to spend time with the patient to take the proper history. Okay. Next slide, SK. This topic was also dealt in the previous session. In introduction, I told you about hyperalgesia. I told you allodynia. I gave an example of a patient who cut her hair because just the hair's weight was also creating pain. So I told the difference between hyperalgesia and allodynia. And I told these are the symptoms. Allodynia and hyperalgesia appears means central sensitization has appeared. So some nociplastic thing has happened. So central pain processing is haphazard now. You have to do something to desensitize. You have to stop the vicious cycle of pain stimulus going in again and again and getting amplified. So we'll have to act with a bigger dose, then start stepping down. So they have to be under continuous monitoring. And I also told you about what is background pain and breakthrough pain. Breakthrough pain, we have to have a leeway of giving an SOS dose. Patient should have the liberty of taking an SOS dose when pain is very severe. They will see us, consult us, and go to their home. When suddenly pain worsens, they should have the ability, they should be understanding. We have to create the awareness and we should give the education of how much tablet can you take at one single time. One tablet of morphine I have given you 10 mg. For 1 hour you have to wait. After 1 hour only you can take the next tablet if the pain has not come down. So when to reassess for their pain, some self-assessment of their own pain and taking the next tablet, next dose. So such things we have to learn by experience and practice. These are theoretically also, this is all available as I told you in the prescribing thing. I told you about the Twycross book. No? Today I have also shared one more comprehensive guidelines book for pain and palliative. I think Dr. Janet Abraham's 4th edition book. So that is very useful for me also for understanding, assessing the spiritual pain or how to communicate bad and some intense discussions how to have. All that is nicely given in that book. You can have that as a reference. And then one more thing is end of dose. I think end of dose failure and incidental pain has been discussed in the last class, but it is very important to understand that when we tell it is difficult pain, patient will tell pain is not reduced, they will tell, or pain has reduced but sometimes comes. So we have to ask them more specifically, tell me more about it. When is your pain not getting control? When is your pain okay? So you have to probe the patient more and more. Ask them, tell me more about it. Tell me more about it. As they tell more and more, you will understand how can you approach it. Like for sometimes, if they tell it is only during dressing change, only when they move me on the toilet commode, I'm getting pain. Only when I am coughing, I'm getting the pain. uh, or when it is with physical activity or with turning from one side to other, then we have to doubt about no vertebral myths and all. So this will give us clue, and accordingly we have to act. So grossly, if we tell something is paining, and randomly if we treat, difficult pains will be there. But when we assess and analyze with more information, we can handle it. End of dose failure means we have inadequately dosed. We have to increase a dose, or we have to keep one extra SOS dose. So whenever end of dose failure comes, when 10 mg morphine I have given, I expect it to work for minimum 4 hours. 4 to 6 hours at least it should work. The patient will nicely tell 6 a.m. you have given a tablet, no doctor. By 9 o'clock itself, before the next dose comes, I'll be just waiting for the drug. So the attender will tell ma'am, she is asking medicine at 9 o'clock itself. She is not waiting for 10 o'clock also. That means we have inadequately dosed. So per day dose, we have to recalculate and divide it and make it as 1.5 tablet. Make it 15 mg in that case. Or in between, you can tell you when you put SR dose also, the frequency SR dose anyway, we are going to do BD only. In between, you can keep an SOS dose before the previous dose is coming. So end of dose failure also we can handle it. Okay. Next slide, SK. Okay, so for this also, for any symptom for that matter, not only pain, I wanted to give you this one guideline which will help you not to miss things. Before we go into severe distress of pain distress, if we are regularly following up, we will not land up in such a situation first of all. If we have found out earlier itself, when the pain score is 6 or 7 itself, we have found out, we will not land up in a situation of 10 by 10 pain crisis or giving an IV morphine trial. We may not land up, but despite that, sometimes we will have to do a route change, give an IV morphine trial, settle the pain, then go back to oral and all. It happens, but still we should be prepared for all that. So what is this EMA acronym is? It's from type Twycross. If we follow this for any symptom management, not only pain, for nausea, vomiting, for pruritus, anything we can use this. Evaluation, as I told you, we have to evaluate again and again. Make clear and accurate assessment of each symptom, even if it is hemoptysis. Accurate assessment is very, very important. And then after we understand, we have to communicate this to the patient that we are working on it, what is happening. Otherwise, the anxiety will build up multiple times and we'll not be able to give the same symptom control. Especially symptoms like breathlessness will worsen with anxiety. Symptom like pain also will worsen with anxiety. Then we focus on management. After we start the management, any treatment, like it might be an pharmacological or non-pharmacological, whatever it is, we have to be monitoring the response to our treatment. We have to see what was a symptom before, what was a pain score before, or what was a delirium score before. Now I have given some intervention. How is a delirium now, or how is a pain now, how is a nausea vomiting now? So we have to be continuously monitoring. And then A is attention to detail. Many times we forget to involve multidisciplinary team. It will be just one phone call away for us to find out from a neurologist, or many times when I have some confusion, just call a neurologist and ask, see, this is what I'm facing. What can I do? Or you call a pulmonologist to ask what this is what my patient is this breathless. This is a cough syrup I am giving. Still she is telling this. What can I do? So like that, we have to use a multidisciplinary team and get as much information as possible. Okay, this acronym will help you for long term. Okay. Next slide, SK. So goal of pain management when it comes to difficult pain is like we should always remember the disease will give some difficulty and treatment will sometimes give some difficulty. No treatment is all our drugs are also having some complications and side effects. So we have to optimize it. What we have to do is analgesia is far more important, but no, not many times we can achieve a pain score of 0/10. We will prime the patient by the way we talk and give hope and confidence. They will be okay to accept 3/10 pain, 4/10 pain and all. They will be still smiling and talking to us. Okay, now I'm okay, doctor, bearable. They themselves will confidently tell. So we should fix a goal setting is one of the important thing. We should know what is the goal of this admission. When you are admitting a palliative patient with pain, what pain score can you bring to? What other symptom control do they need? What will be the goal when I'm going to discharge this patient? What should I have achieved? So goal setting is very important. For that, this 4 A's we should know. So analgesia should be optimized. And what is the functional capacity of the patient? Cancer patients, we use that KP score. There are scoring system for functional capacity, like activities of daily living, ADLs we call, right? So we should know how much patient is functional. Can he walk? Should I get him back to that walking position? Or should I get him back to the position where he was going out to work and come back? Or he is on his own when family is away. Some cancer patient will be at home when the whole family is away. Evening, they will come back and see the patient. Such situations happen. So what this patient is, what is expected out of this patient, how my care should not interfere in this kind of situation. So activities level, we should know functional activities, then adverse effects of the treatment what we give and the other treatments what is going on, we have to remember. And then aberrant drug taking, that is very uncommon in India, but for other countries it has been very much stressed. We still do not see much of opioid use disorder. It is very, very less in India, but it is very good to monitor all that. Is there any drug seeking behavior? We should explore. If we doubt one, we should have that format. You will be given with a format to rule out opioid use disorder. There's a form which we fill. There's a tool for it. OUD tool is there. So use a tool to find out if this patient is having drug seeking behavior. If you are doubting on, you can involve a psychologist, psychiatrist or psychologist and rule out drug seeking. And then affect and mood is psychological aspect of pain. So we have to always remember the total pain concept. These are the goals of pain management. Next slide, SK. So this one is a slide which this is that white paper consensus I wanted to share. If some people have not seen, I'm sure this would have been discussed earlier. The all other drugs would have been discussed, but always methadone will be little difficult for us to understand because we do not use it frequently. So even when I go to Pallium only, I get to see the use of methadone. It is not very freely available in many parts of the country. And we need some expertise and some experience in using methadone. Whenever we want to do opioid rotation, we have options like fentanyl. When we want to rotate morphine, what are the options we have is, one is we have buprenorphine. We can rotate buprenorphine or we can rotate fentanyl. This is what we have now. Methadone also we should get used to, and there are certain things which we have to see before using methadone, like baseline ECG. Is there QR prolongation in the baseline ECG? Can I start methadone for this patient? And all that. So this paper I just wanted to give for reminder. Other drugs also would have been discussed for you in the previous classes. So keep in mind, opioid rotation is not the answer for every question. You should not immediately jump and change. Oh, morphine is not working, I will go to a drug which is better than morphine. First of all, we should rule out other causes. Some simple constipation might have been causing a difficult pain sometimes. Refractory pain, there might be some simple issue. So we have to pay attention, rule out everything. Then we should see that, okay, more than 200 mg it is going, morphine dose is increasing so much. Now I can change over to some other drug. That decision, it is very, very rare. It happens very rarely, but we should be aware of that. Okay, next slide, SK. These are some references which you can get back to. If you want some guidelines, please use this. Guidelines and references for cancer pain. And what I have given to SK is also a very nice guideline book for both opioids, pharmacotherapy, non-pharmacotherapy, spiritual care, social pain care and all. It is a good guideline. On next slide, SK. This is for non-cancer pain guidelines. You can go back to this reference. These articles, these websites will give you, this is, I think, UK guidelines. It gives you nice, all the detailed things of pharmacotherapy, non-pharmacotherapy, multidisciplinary, and the level of evidences. Everything is in this article. Next slide, SK. Okay, now there is not much of theory involved now. I've told you about opioid rotation. I told you about attention to detail and all. So this case is, long back I had seen this case. She is a 63-year-old female. She came to us with right-sided weakness and right-sided chest wall pain. Okay, this is how she presented. Some elsewhere she was treated as stroke because she had right-sided weakness. And they had started given clopilate and aspirin and sent to a hospital, a teaching hospital like our hospital. After coming here, the CT showed that there is a space occupying lesion. Then it was found it was a brain mets. Then chest pain was there, breathing difficulty was there, chest X-ray showed pleural effusion. Then they took a HRCT which showed that there is a lung, CA lung is there, there is a space occupying lesion in the right lung, and the pleural involvement is there. That is why she is having continuous pain. So for this patient, what pain management can we start with? So what thing I'm telling you is, what information I'm giving you is, pain level is 8 to 9 by 10. What analgesic plan should we start with? Do you have any suggestions? Titrated dose of IV morphine. Okay. So, okay, to start with, definitely IV morphine is a choice to start with. But how long can we give IV morphine? Okay, then we can convert it to oral morphine. That will be a good idea. So there is something called IV morphine trial. I hope it would have been discussed earlier with you. So how do we give IV morphine trial? How frequently should we, how much milligrams do we start with? Was it covered in your sessions? Any one of you can unmute and tell. Okay, you have discussed this already. So you can, you write a pain score, you record the vitals, you record the respiratory rate, and you put an IV line, you dilute it into 10 mg morphine into 1 mg per ml, and you start with 2 mg or 3 mg. Every 10 minutes, you ask the pain score and then give the next 1 mg morphine, 1 mg morphine, 1 mg morphine. You can keep adding. And then at one point, you'll achieve analgesia of less than 5 score. So now the pain score is written as 8 to 9. Once the pain score is achieved less than 5 or tolerable, less 3, 4, 2 and all, the morphine constitution is subjective. If you have an ampule, like my hospital has 10 mg, so I make it 1 mg per ml. If you have a 15 mg vial, then you ampule, then you can make it 1.5 mg per ml. It's completely subjective. Based upon availability, you can handle it. So once the target pain relief is achieved, patient is comfortable but not drowsy. So when do we stop the IV morphine trial? When patient analgesia is achieved, you can stop. or vitals are like patient's vitals are getting unstable, then you should stop the trial. Or when patient becomes drowsy, you stop the trial. Okay, so endpoint of IV morphine trial is either vitals are unstable or analgesia is achieved is a primary goal. The other things when to abort the trial is patient became drowsy, then you stop the trial. So you take that dose as a end or target dose what you have to give. So with that dose in mind, like if I get like 5 mg or 6 mg, you calculate that is going to work for 4 hours only. So for 24 hours dose into 6, you have to multiply. And then multiply that and then give it into 5 divided doses. Night dose, you can put it as double dose. For example, if you get 10 mg, you are going to give every 4th hourly, like 6 a.m., 10 a.m., then 2 p.m. for lunch, then 6 p.m., 10 p.m. This is how you are going to write a prescription. I'll show you a model prescription also. So along with that, the night dose 10 p.m. dose only, you have to write double dose, because otherwise patient will have to wake up in the night. So when you are writing instant release morphine, you will be writing 10 mg, 10 mg 4th Q4H, and at 10 p.m. dose should be 20 mg. For this particular patient, she was a thin patient. I started with 5 mg only. Night dose was 10. Because she was having an SOL and all, I didn't want her to become very drowsy. So I started with half tablet morphine, 4th hourly, and 1 tablet in the night at 10 p.m. So slowly, first day it was not adequate. So second day I made it 1 tablet. Her kidney functions were normal. Her kidney and liver functions were normal. It was checked before initiating the treatment. After that, slowly, she became drowsy. The same patient, she became drowsy. Then I had to reduce the dose to half tablet again. And after few days, for the pleural effusion, they had inserted. It was not coming down, and the pain was because of the pleuritic type of pain. So they wanted to tap, and they put ICD. Okay, so for that we had to add NSAIDs also along with that. Now because of that ICD, whenever it touches, she had pain. So I had kept 1 SOS tablet whenever she tells extra pain, and added NSAID also to handle the ICD insertion site. Then slowly it was tapered and stopped. And 3 months later, she came with a fracture femur. Okay, by the time she was not on morphine. After this pleural effusion was tapped and all, her pain has come down much. So we tapered and stopped morphine after 2 months or something. She never, like how it was tapered was, morphine was made TID, morphine was made BD, morphine was made only HS, in the night only pain. When I turn, only it is paining. That time only night you take. After some time it became SOS and it was stopped. So after all these 3-4 months later, she comes back with a fracture femur. That time, again, routine things were started. Along with that, some epidural analgesia was also given. Luckily, she did not have a vertebral meds. She was given epidural analgesia also. Went back on morphine for some time. Again, morphine was stopped. This was one patient whom I could stop morphine also. Cancer patient whom I started morphine. Few months, again stop morphine also. Next slide. Next case. Okay, I think, can you see the prescription, how it is written? This is what I have just put over the label. See, she is 53-year-old female. I've written the diagnosis there for my own reference. Triplicate copy of this prescription will be written. So we write 3 copies. 1 copy will be with my file. 1 copy will go to the pharmacy. 1 copy will be going to the patient. Okay, tab morphine 5 mg only I have written. Can you see? It is like half tablet actually. For sometimes I also give it as syrup. My pharmacy is like very friendly. They make syrup for some patients who do not want tablet. Next is bisacodyl I have written. So every time we chart morphine, we have to write a laxative. So bisacodyl is a stimulant laxative which will work for opioid-induced constipation. So the drug of choice will be bisacodyl or any stimulant laxative we can write. And then Perinom I have written. First, this is when I am initiating opioid therapy. I have to give antiemetic Definitely. What antiemetic is a drug of choice is some pro-kinetic drug only. More than emised, more than ondansetron. Ondansetron is centrally acting. So we have to choose a pro-kinetic. Yeah, that's good. Yeah. So perinom is a drug of choice for opioid. Metoclopramide is the drug of choice. Domperidone is rarely used. Metoclopramide is a drug of choice. So TID, it has to be given TID for 3 days at least. After that, patients will get used to morphine. So when you're writing morphine, you have to tell them also that you for few days you will get drowsy, but you'll be okay after 2-3 days. If you feel excessively drowsy, please come back to me or please let me know. Or if you are giving an IP setup, you have to tell the nurse that patient will become little drowsy for the first 2-3 days of morphine. It is natural. Don't get panicky. If she is excessively drowsy, not arousable at all, please call me. And then the last one is I have added some amitriptyline also because she was very anxious and then she has a brain meds also. So for this patient, I had added amitriptyline also. Next slide, SK. So we have to get used to writing prescriptions of opioid prescriptions. So this is one other patient. Okay. This is a next case. I think this is CA lung with meds. I get a lot of references from pulmonologists for stage 3 and 4. So this prescription I kept because this is sustained release, like more content sustained release or CR we get. This you can see BD is written, 20 mg BD is written. So this is given for 1 month. Okay, it is 120 tablets have been dispensed to a patient. Along with that, I've written morphine plain as SOS. They can take 1 tablet of morphine extra. So that gives them the liberty of handling that end of dose failure or incidental pain or breakthrough pain. So that is why I put a sample prescription there. Okay. Then finally, bisacodyl. We should never forget to write the laxative tablet. This is on last year's prescription. This is a stable pain patient. This was one patient whom I told she used to go for that government work scheme and all. With this tablet, with this long-acting morphine, why I changed was she told I'm going to work in some government scheme for 100 days. So you write me tablets only for morning and night. Don't write this every 4-hourly tablet and all. So I changed. And it worked out very good for her. I think for 3 months or 4 months, she was on this prescription only. I used to refill this kind of prescription. After some time, it worsened when metastasis worsened, like scapula was involved, pain worsened. I had to again change her back to morphine plain. I had to re-evaluate her, take a CT again, send her for palliative chemo, palliative radiotherapy again, and all that happened. So whenever bone meds come, we should remember about palliative radiotherapy also. Very good role is there. Okay, next slide, SK. So that's about stable pain. This is a good, this is an interesting case. This was my exam case presentation also. This patient, no, he was some 75 plus patient and the husband and wife, they did not have children. He will have neuropathic pain, herpes zoster. Can you see on the thorax dermatomal lesions? So he will have herpes zoster pain also. First, I didn't expose him completely and see. Initially, I did not see. I did not know why this chest. Every time he'll tell chest pain. I was thinking it is pleural meds pain. Why I put this slide is we sometimes do not explore enough. Then I understood this is because of this herpes zoster. Gabapentin was added. It helped. Morphine itself helped to reduce this pain, but whenever it is cold and all, he will get this exacerbation. So that time pregabalin or gabapentin will be added for this patient. And because he becomes very breathless, I can't put a bigger dose of morphine also. For this patient, I had to use syrup morphine only. That too only BD. It was not started for pain per se. It was started for breathlessness. This morphine dose was started for breathlessness. So all the chest pain this patient was complaining was because of this herpes zoster, which I realized after 3 visits only. After 1 or 2 admissions only, I understood what is the problem. So you can see him having a hand fan in his hand. So these are all for symptom reduction we used. We push his table nearby the toilet, because if he walks to the toilet, he'll become breathless. If he has constipation, if he strains to defecate, he will become breathless. So we had to handle other aspects, physical aspects of breathlessness and pain. So this is what comes in disguise as difficult pain to us most of the time. Next slide, SK. This is also an interesting case. This was the very first time when I used in pediatric patient morphine, oral morphine. Even our pediatricians were very excited to see, oh, madam, morphine can give this much relief. Thank you so much. Like that, they were all, the pediatrics department was thanking me. They had this patient, very nice kid, very talented and smart kid. He was almost banging his head on the steel cot. He used to, they never slept. The parents and the child did not sleep for 7 days. Mother is having a small kid, so mother will not come. Father and grandmother will be there. This kid was given, according to WHO ladder, paracetamol was given, NSAIDs were given, steroid was going on. He was diagnosed as acute demyelinating encephalomyelitis. This is a classic example of central neuropathic pain. And luckily, morphine helped for this. I just started with 1 mg morphine because I was so scared. I used to consult. I've never given morphine syrup for any kid, no. So this was the first time I used, and with 2 mg morphine. Third day, this guy was nicely laughing, and so the first time he slept, and like the parents were very excited. This kid was on morphine therapy for 2 to 3 weeks, complete 2.5 mg morphine for 3 weeks or so. Then we started titrating down. By that time, they collected enough money to give that IVIG therapy. That was, they couldn't afford for every scan, everything, like, IVIG therapy. He was told for plasmapheresis and all. So every time some rituximab or something was prescribed, some monoclonal antibody was prescribed for this patient. Until diagnosis came only, it took 7 to 10 days. This kid was in so much of distress. So right time we gave the analgesic, we escalated it, then we tapered it, and he is now drug free, no morphine now. The disease settled, pain settled. So this was for headache we used. This is central.
Sorry, Punitha, sorry to interrupt you. There's just one query in the chat box. This IV morphine to oral morphine conversion. I thought better to clarify that then and there. When they do, I think if the Shruti, Dr. Shruti, is it when you're doing the trial and converting it to oral? Is that your doubt? Please respond so that yes. So just Punitha, I thought it's better to clarify then and there.
Yeah, Shruti, actually, how much mg of morphine is there in your ampule? You get 15 mg morphine ampules? 1 mg. One ampule has 1 mg morphine. No, morphine comes in either 10 mg or 15 mg. For some places, rarely, previously 8 mg was there. So when you dilute it to 10 ml,
Punitha, it is 10 milligram because previously she's messaged titrate dose IV morphine 10 milligram. In the previous chat box, she's mentioned that I think there it's available in her place as 10 milligram vial. Yes. Okay. 10 ml of one vial.
So 10 mg will be there in an ampule. So you take 1 ml of morphine, add 9 ml of saline, make it 1 mg per ml. Or if you have a 15 mg, you make it 1.5 mg and give 1.5, 1.5 or 3 mg as a first dose, and then give 1.5, 1.5 every 10 minutes to titrate to the targeted analgesia level. So that's a good observation. But always it comes in either 10 or 15 only. Accordingly, you can dilute. So next thing is, when you convert IV morphine to oral morphine, what you should remember is you should calculate the 24-hour requirement of morphine first of all. Then only you should oral morphine requirement, OME, we calculate, no? Like the 24-hour morphine requirement, you have to calculate. Every 4th hour you have to give. So IV morphine will be naturally more potent than oral morphine. So the dose will be a little more than IV morphine when you convert it to oral morphine. That's why we keep that SOS dose. So the readjustment of morphine dose comes with 2 weeks time, 1 week time or 2 weeks time. When you call them for next visit only, you will understand what is this patient's morphine requirement. So immediate requirement you will calculate in IV in inpatient setup itself. When you send them for discharge with oral morphine, after 1 or 2 weeks only, you'll be able to understand what is his real morphine requirement. Okay, next slide, SK.
Punitha, sorry, I think with her question, for example, just to make things clear only, I thought, for example, with 5 milligrams of morphine, that patient achieved less than 5 pain score means. So you start with 5 milligram 4th hourly.
Yes.
I think that is what they wanted. Like IV to that point of time, you equate and start. But what
Yes.
Dr. Punitha explained is what you have to remember. See, that 5 milligram is just the 4th hourly dose. You have to calculate the 24-hour dose. So the whatever gave relief, we start that equal morphine tablet, but make it for 24 hours. Then these type of patients have to be reviewed once in 2 days until they achieve the correct dose. See, that point of time they achieved. Then through the day, this SOS and all are needed, because when they came to hospital, they were just sitting in the bed, you gave IV. And then when they go home, are they going to be sitting all the time? You have to be practical. They have to do their daily living or day-to-day activities, personal activities. So that is why the 24-hour dose is also equally important, as Dr. Punitha has explained. So I think with these two explanations, the query should have been satisfied. If not, message again.
You can just give like whatever dose you have achieved, you can start oral. Like I achieved with 7.5 mg means 7.5 mg you can.
I think she has replied that she is understood, Punitha. Thank you. Just to make things clear, because I thought these are all very, very basic. And this is what they need to know when they are seeing patients. Okay?
Yeah.
Thank you, dear. Please
will
go
only
ahead.
give confidence to prescribe. So this is a patient with multiple lung myths and breathlessness. Because he was breathless, I couldn't keep increasing morphine also. Still, this patient was given syrup morphine in 2.5 mg, 2.5 mg. I was giving, escalating. We'll see him. If he becomes breathless or drowsy, we'll reduce the dose. So, as ma'am told, continuously evaluating. Every day or other, evaluating the patient, close communication with the pulmonologist. Patient is not doing good. Patient needs NIV. And some mishap. I have shared this story to many patients, in 2-3 forums also. Once one patient, I prescribed IV morphine. When patient, I think this is the same patient or a different patient, like same scenario. He was requiring NIV, and pain was there. He was not able to swallow. So oral morphine was changed to IV morphine, and for that patient, I had not given any antiemetic. The patient vomited after 1 mg morphine. Patient vomited with an NIV mask, and he aspirated, and he passed away on the same evening. So both the pulmonologist and I were feeling very guilty about it, and it was some 3-4 years ago. So we used to discuss what happened, where it can. I should have given IV metoclopramide. He was on all oral prescription, so oral medication dose was still pending or something like that. He vomited, and they did suction and all, but still, no, he aspirated and passed away. So this patient was already in end of life. So this is where the doctrine of double effect comes. So you will be learning that also. I think there will be a session, no, all these things will be dealt. When we intend to do something, the side effect of it can do harmful effect also. So sometimes it happens. We have to be extremely cautious for legal reasons also, for ethical reasons also, for our own safety. And we should have some protocols. So when protocols are in place, we will not miss such simple things. Okay, that is just when I share this, you will every time remember to write an antiemetic. When I tell this story that some patient vomited and aspirated on NIV after morphine, you will remember to write an antiemetic. Okay. Okay, next slide. Okay, ma'am is telling it will be covered in ethics. Okay, this was one of the difficult patient I handled. This lady, her husband was a smoker who will smoke only indoors. He won't smoke outdoors. Outside and all he'll never smoke, but only in house he'll smoke. She became
active.
Somebody's mic is
Sangeet,
unmuted.
please can you mute the person, whoever is speaking, Sangeet?
So for this patient, there was refractory pain. Can you see from the PET scan where all the mets are? Can you see from the sternum there are mets? In the liver there are mets. The liver is enlarged. The liver is almost occupying half the abdomen. And can you see the vertebral mets in the PET scan? So this patient used to have severe back pain. So what I did was I started steroids. What is a palliative care emergency when you see such things, when a vertebral mets with some nerve compression signs. This patient, one day she had maturation difficulty. So immediately she was given IV steroids and referred to radiotherapy. So they will give radiotherapy to reduce that, and reversibly that at least a neurological deficit we can save them from becoming paraplegic or something. Can you see in the last place where the vertebral mets are there? So she lived after that radiotherapy for some 20 days or 30 days. She was so breathless. She's a CA lung patient, lung cancer patient. This many mets were there. For the liver mets also, initially she came with abdominal, right hypochondrial pain only. That was also liver capsule stretch. For that also the treatment is dexamethasone. Dexamethasone is such a versatile drug. Many time in difficult pain, our only resort is going to dexamethasone. So for this abdominal pain also we had to give dexamethasone. For that spinal cord compression also we have to give dexamethasone. Radiotherapy is palliative radiotherapy is very important. At least one radiation or two, whatever the radiotherapist feels appropriate, radiation has to be given. Many times for brain mets, whole brain radiation they give. Single time also they give one. And then for spine also, we should involve the radiotherapy team immediately. So that will reduce the pain so much. So I think this is the last case, I think. Next slide, SK. I think I have some 2 extra slides in the stock. SK, okay, next slide, SK. Okay, I think this has been already told, and this is just to reinforce that we should never forget this. Many times, if you miss something in this, the pain becomes difficult. Okay, next slide, SK. Something else. Oh, this was also told in the last class. Next slide, SK. Oh, that's all. That's all, nice. Okay.
Yes, ma'am, that's all.
Okay. So the final 2 slides are again to remind you that total pain cannot be forgotten. Many times this why me question, why did this happen to me question, and all will come. No, there is nothing like difficult pain. We have named it like that because we face difficulty in handling pain. I've given this, I've given that. Should I use rotation? Earlier, I'll be always thinking, oh, this is not working for morphine. Maybe I have no access to methadone. What will I do? I used to be behind my pharmacist to arrange methadone for me. So such things, opioid rotation concept and all, I didn't get a hang on until I saw many patients whom, when we go into details, many times we can handle the pain. So there's no particular definition for difficult pain. We can call it as refractory pain. So why is this refractory nature happening? What is missing? Is there a new advancement in disease? This much if we think that is it. So I think we can go to the case presentation and then we can finish with the discussion.
Thank you very much, Punitha. First, I have to applaud you. How many of us will be willing and bold enough to say, what did she say? That when I saw the patient, I was thinking it is metastatic pain, but it was episode. Not only Dr. Punitha, all of us can do that. Okay? No, there is no, see, ultimately, I always keep telling one statement. My aim and goal, practicing this profession is, I want the best for my patient. Okay. Is it that only I should do it? I want the patient to get the best. If I find out something that somebody else can give that best relief to that patient, I will not hesitate. And I should not hesitate. I should be brave enough to be like Dr. Punitha. Okay. There is no shame, no failure, nothing. Is that put yourself in that patient's shoes. What is that you will want? I'm not going to give you answers for all this, okay? All of you have one inner self. Just think and work and be happy and satisfied to that self. Okay, so that is one thing. And then next is this difficult pain, no, is something you and that 4 A's and that 5 thing, no, that slide is very, very important. Because, for example, if it's a stage 4 CA, they are in such a state, okay, multiple metastasis, they can't do anything. So there, can you achieve 0 by 10? Am I failing if I not achieve 0 by 10? No, there is where you need to know what is the goal that I can achieve. Next, teach the patient what they can do. There are something called as chair exercises, just sit, stand exercises, because that patient is in a state, I just cannot do anything. I cannot move in my bed. See, all these things you have to see to believe. That is why again and again, hands-on, 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 hands-on only can give you that. You cannot imagine these things. What's the guarantee that you will imagine in the right way? Again, don't think that always patients will only struggle and die. As she said, I have also had an experience, stage 3, stage 4 CA lung patient who could not do anything. She was a working lady. Okay, so suddenly she got to that stage, nothing. So just with morphine, she got to a stage where she could cook for the family. And she just lived like that and she died just like that, nothing more. That morning she cooked and that afternoon she died. What? 10 milligram morphine, 4th hourly she was having. Not even SR she didn't need. As I'm telling, I gave 2 months prescription dose. First time 1 month for titrating everything. Next 2 months we gave. So, and then in that itself, the daughter came and returned the remaining medicines to our center. And she said she was, daughter was so satisfied. She said, Mom felt that she was to do everything. Now she can't do anything. That was her main concern. So she did everything till the last day. So that her, see, inevitable, her lifespan was for that 6 weeks. But did she get a better quality of life in that 6 weeks? Is that what we have to see? Okay. So understanding, reviewing again and again, multimodal management, and then asking the question, are you taking the tablet properly? Sometimes they may say, no, non-availability, no one to give me 4 hours. See, these things many times they may not say. Because why they don't say, oh, my family is looking after me. They are going out and working for me. And now if I complain about them, what is that I'm going to get? So this no fault finding, no feel of guilt. Everyone goes through all this. So telling them, so sometimes these type group activities, when they see someone, oh, it's not only me struggling. There are so many on this earth being in my same position. So there are so many factors like that. So put everything together, assess, reassess, then go back and see what. So other modes, opioid rotation is something very important. Adding just like normal paracetamol, diclofenac, they do wonders. PR suppositories, diclofenac suppositories per rectal, along with thing, not as a routine, just one-off, incidental pain you can manage. Then dexamethasone, again. You would have had sessions on like adjuvants. So adjuvants should be remembered because when the pain, especially radiotherapy, chemotherapy, can all cause neuropathic pain. So all that has to be kept in mind. So again, I'll repeat every session, multidisciplinary assessment and multimodal management is the take home all of you have to take. You have to get the psychologist. You have to get the physiotherapist. What can I do? Okay, I can help this patient. You should ask them, what is that you want? They'll say, no, as she said, I just want to go to the bathroom by myself. Get the bed close to the bathroom, or give a wheelchair, or tell them to take the medicine, just shower I want to do. 45 minutes before shower, take your bath, take the tablet. So many simple tips. Many times they say, oh, this was not told to me by any doctor. Are we doing justice? Are we just giving tablet alone and not telling them how to take it? Do you feel okay in that? So just think these little things. All of you know everything. Okay, there's no one like that. Every book has. As Punitha, we have shared that book information in that WhatsApp group already. Okay, so read, you see, and use it for your patient. Okay,
yeah. So we have to read lots and use it for the patient. I had one interesting case. There was an ICU nurse. She was having acute sinusitis headache, and she's a known migraine patient. Last 2 years, no episode. Now she got headache, and because she was an ICU nurse, they had started on paracetamol. They have given naproxen, and there is a combination, headset. They call it headset. The neurologist has seen, ENT people have seen all that. They have started on sodium valproate, amitriptyline, and everything. And finally, pain didn't come down for 3 days. Then pain clinic reference was given, and I had gone and seen her day before yesterday only. All that I had to do was readjust the dose of paracetamol. She was given 650 paracetamol. I made it as 1 gram paracetamol. Acton OR tablet is there. No, that's 1 gram paracetamol tablet. All that I did was I cut off all sodium valproate. Sometimes a neurologist will get to know about this lady is coming in, changing my prescription. It might happen, but sometimes I directly, to avoid such clashes, I directly call and tell, so that it doesn't, professional things should be maintained. So I tell, sir, paracetamol dose, I have just optimized. Let us see, sir, if it works or not. Now, yesterday the patient is discharged with Acton OR and naproxen only, and headset tablet only. Sodium valproate is stopped, amitriptyline is stopped. So we should not jump to conclusion by adding that, okay, some neurologist has seen it's not stopped, amitriptyline is going on, sodium valproate is going on. What am I going to do? It is a difficult pain and all. Go back to basics. See whether paracetamol is given in the right way, first of all. That's what I did. It was not given adequately. Paracetamol is not given adequately, and we expect headache to get treated. So all that I did was change from 650 paracetamol to 1 gram paracetamol.
Question in the chat box: can you give morphine along with chemotherapy? Yes. You have to have a chat with the oncologist. Okay, see the patient as a whole. Okay, and one more thing to add on to that paracetamol, what she said. Sometimes just timing. No, for example, 6:10 to is your morphine dose. Just make that paracetamol as 8 o'clock. Like give 2 hours time, and put, rather than giving the morphine and paracetamol together. See, this and all common sense, and see what. And if that patient is not going to have anyone with them, no one to give medicine, that may not work. But if there is a patient who has a good carer, or the patient himself can take, is educated, is willing to do, so there's no one size fits all. And if one size fits all works, there's no need for us as doctors. Okay, you have to do that special little bit.
Yeah,
that is the plus and that is the minus. Okay,
yeah.
So you're all God willing to pursue, pick the positive in it. You spend that 2 minutes in a common sense way. Put two and two together. See, how can I help? So these things are very, very important. So just that 6 o'clock morphine, 8 o'clock paracetamol. So their pharmacology, continuous baseline drug level, blood drug level you're maintaining. Okay, same bio.
That is one important trick. What madam told now is an important trick we all use. Do not crowd all the analgesics at one time. Like one morphine is going at 8 o'clock, then 10 o'clock you push paracetamol too. So that round the clock pain relief is there. You are not overdosing with any single drug. That's one important trick we all should learn. Timing of the drug.
Only if you see patients, you will know all this. See the number.
Only by practice it comes. There's a lot of room for creativity in pain and palliative.
Exactly.
You can become more and more creative.
Common sense. That's why I'm
Yeah, that-
telling all of you know everything. Okay, just pick the points. That's all. No rocket science. Okay, no to all of us are capable. I have the potential. We can do it. Okay, just that little bit interest and passion is needed. That's all. Okay. The case presentation, the person who was supposed to do for some internet reason is unable to. So I'll because it's
read out the
something
story,
like,
ma'am.
I'm going to just read it, dear. Did you say anything, Punitha?
Ma'am,
Then
I have seen the history also. We can just, you can read it out and we can just go to the discussion questions.
exactly. That's what that I was also thinking the same. I would just give the information. We'll go for the discussion straight away. Sangeet, can you share, please? Next slide. Leave it there. It's a 84-year-old patient with a female patient with diagnosis of CA ovary with bone metastasis in the spine mainly. Next slide. Her pain was severe, sharp on the left hip for 3 months, radiating to the thigh on the left side, and it gets exaggerated on activities, mainly walking, bending, and there was difficulty in getting up after lying down. And so basically all activities. So she's unable to do her household work. And she also had sleeplessness, tiredness, and loss of appetite. Next slide. The discomfort and pain, she also had discomfort and pain in the abdomen 20 years back, underwent MRA, which reported mass involving the ovary and uterus. So biopsy was done, which showed adenoid carcinoma of the ovary and uterus, and that she got operated and underwent chemotherapy. Okay, then she was on regular follow-up for 10 years. Then she started having severe back pain since 3 months. So 20-year history, 10 after that, she's been followed up for 10 years. The last 3 months, her pain worsened. MRI was repeated, which showed recurrence of the lesion with spinal metastasis. She didn't have any other comorbidities. Next slide. From examination, there was severe tenderness in the left iliac joint and also at L4, L5 region. Her pain score was 9. She had weight loss and she was very weak. She was irritable and low mood. When someone is in so much pain, mood is bound to be low, and always we've been telling pain and mood are strongly connected. That is, when someone is in severe pain, mood is low. So when mood is low, pain will become more. Okay, and there is clear MRI studies which have proved this with chemical and blood flow changes. Next slide, please. I'm just adding on the information because more so better to know what is the connection and things you need not think like that. Okay, what treatment did she get? She had MRI and PET scan for the spinal metastasis, and her CA-125 was raised. She is already on oral chemotherapy and undergoing physiotherapy too. She is on tramadol. Pain is still severe, no relief with physio, and she is continuing to do her activities with severe pain. Next slide. Psychosocial, she lost her husband 2 years back. She is living with a son who is working abroad. So she was staying with her younger sister, who also left because she had to go be with her children. So basically, patient is by herself, being looked after by a maid and some distant relatives. So now she's really wondering her spiritual concern. Why on earth? Why am I struggling? Why this is happening to me? Next slide. Her main concern is severe pain has come so that it's impinging on her daily activities. As I said, every work. Already her main complaint itself was that movement is causing pain. And how on earth? She's now by herself. How on earth she live? This query will be there in anyone's mind at that point of stage of their life. And she's also having sleeplessness, tiredness, and she has no one who really loves and wants to look after her. The only one son who is unmarried, who went abroad, recently got a job from. So basically, he had to go for the job. So younger sister also, we said why she had to leave. So now she's wondering why no one is there. Whoever is there also is unable to take care. Next slide. So summary, like I'm going to give you in a nutshell rather than reading the whole thing. 84-year-old lady who had CA ovary, had treatment 20 years ago, followed up for 10 years. But in the last 3 months, all her symptoms worsened. Every activity was causing pain. So she had an MRI which showed some metastatic lesions. So next slide. So what all treatment she's had? She's on chemotherapy, and her pain is quite high, but she's only on tramadol. And then psychosocial, she has got so much of impact. Okay, this is the time when she needs someone. So she's lost her husband and only one son. That son also has gone because he needed a job, so he had gone abroad. And her siblings, that is her brother and sisters, are unable to be with her. So she's with no other choice, she's by herself. So her spiritual pain element also is quite strong. So that is the nutshell. Next slide. She's had physiotherapy and things, but unfortunately, nothing is helping her. So now what are the discussion points? How to manage her physical pain? And does she need palliative care? How to explain to her about the recurrence and bony involvement? How to deal with her psychosocial issues? How to deal with loneliness and fear? Punitha, we can go ahead. I think 1, 3, and 4, we will have an entire session on it. But you can take over from there, Punitha.
Okay. So for this patient, obviously, palliative care is the need of the hour. So now we know there is a disease which is recurred after 20 years. So definitely she needs palliative care. She will benefit from palliative care because we are going to give her a total pain care, like total care. And how to manage her physical pain? There are some inadequacies in taking information from for this patient, especially is it neuropathic pain? Are we sure about it? Or is it somatic type of pain? Many a times this, first of all, CA ovary, she has survived for 20 years after surgery itself is a good thing. And she's 84 now. Maybe at 64, she has had a surgery. CA ovary, we know the prognosis, right? So we can talk to her in that way. For the physical pain per se, 8/10 pain or 9/10 pain warrants morphine. Given her age and chemotherapy, RFT, LFT should be checked. Renal function and liver function should be checked. An appropriate dose of morphine should be initiated. Tramadol might be a good choice to start with because there is a neuropathic pain component in it. But is it really nerve compression? MRI should guide us. Is there any radiculopathy symptoms? Is there straight leg rising test will be positive if there is anything. So yes, Siddharthini has put rightly. So the need of the hour is radiotherapy should be involved. And if there is suspicion of cord compression, spinal cord compression, steroid should be initiated. Dexamethasone, 16 mg IV. OD should be started with adequate gastric prophylaxis, like Pantocid or esomeprazole, or good gastric prophylaxis should be accompanied with Dexa. Dexa should be given only in the morning, and IV big dose 16 mg Dexa or 24 mg Dexa is also okay. And as Dr. Shanmugh Sundaram has added, bisphosphonates have a big role before we start. So my regimen will be definitely, I always ask for, when I get a patient like this, I ask for RFT, LFT, calcium levels. When I see creatinine is okay and calcium is acceptable, then bisphosphonates, zoledronic acid, 4 mg only I generally start. In 100 ml syringe, zoledronic acid cannot be pushed fast. It has to be given slowly for monthly once or 1.5 month once or some 6 weeks once or something. You can time accordingly zoledronic acid injection so that the osteolysis doesn't happen. The collapse of vertebra doesn't happen so easily. In the history, iliac bone pain is also there. There will be osteolytic lesions if we see the iliac bone. If there was an X-ray, we could have easily seen the bony osteolytic things. So only in the vertebra, the MRI is mentioned. Yeah, zoledronic acid can be given over 15 minutes. It's our comfort. When we want to avoid anything, I sometimes even give it up to half an hour or 1 hour. There's no hurry in giving zoledronic acid because it's a completely elective part. So it can be given slow infusion. at least 15 minutes, more than 15 minutes, up to 30 minutes or 1 hour we can give, because some people develop some hyperthermia or hyperemia when we give zoledronic acid fast. So we'll have to be giving some steroids sometimes. Very rarely it has happened. So other option is, other important thing is not option, it is to be done as palliative radiotherapy. For this patient, targeted palliative radiotherapy will reduce pain definitely. So radiotherapy should be considered, morphine should be considered at right dose of morphine. You should see if creatinine is high or liver function is affected, then the dose should be half the dose and time it accordingly. For a renal failure patient or a, liver failure patient, you have to give low dose and infrequent doses. And every dose should be, you have to observe. You can even start from 2.5 mg. Just observe the patient. Is he becoming drowsy? So morphine, titrated dose of morphine, and dexamethasone IV, a big dose of dexamethasone IV. Zoledronic acid is still prophylaxis. It's not going to help immediately. Zoledronic will not help in overnight. But radiotherapy definitely helps overnight also. Steroid will help overnight. So these 4 things are the pillar of such a case. Morphine should definitely be started. Tramadol, we have to move to the next step. Step 3, we have to go. And the next question is how to explain about her recurrence and bony involvement. As I told, we did not scare her, but we can definitely tell this many years of after the surgery, the recurrence of disease has not occurred for 20 years. After that only she has got recurrence and all these things. So you can tell only this part has been affected, so this will be treated, your comfort will be taken care and all, we can always tell her. And practical, we can give hope, but it should be practically, what sometimes we have to tell them that, okay, can we arrange a meeting between you and your family and us, your son? Can we have a video call with your son? We cannot scare both of them, but still we can understand the situation. When the son can come, can he come 6 monthly once? Can he come 3 monthly once? Who's the next of the kin and all? So dealing with psychological issues with practice, when we are along with the senior practitioners, you pick up some things by your own style, you'll pick up something, psychological issues, handling psychological issues. How do you handle patients in depression, patient in anxiety, aggressive patient, and all these things? How do you handle? You learn by seeing, and when you are working closely with the psychologist or a psychiatrist, you see them counseling. How do they approach? The same skills you can pick up. So there are certain skills to pick up. Main thing is active listening. Let the patient talk. Let the patient talk and then find out what are the fears in her. What are the things which needs immediate attention. So such things, if it is like she wants to
like, see, they have not yet had any session on communication. So I think our communication sessions deal a lot on how to explain, what to explain, where to explain, how much to explain, and in small chunks, all that they will have that, I think. No, so that will, I think, 2, 3, and 4, no, will be covered. You will have 3 sessions on that.
Yeah. So pain per se, I feel there needs to be more evaluated. The history, the X-ray could have been put. Last time I told you about body chart. No, that could have been big help, because ovary cancer mets generally happens in thoracic vertebra. But in this MRI, we have seen it in lumbar vertebra. What if it is some incidental lumbar disc prolapse or something? It can be. It's not always, but generally thoracic vertebra only we see mets, because it's a more vascular area. But it can happen in lumbar also. We cannot. There's no hard and fast rule. But whatever I'm telling is common. So a PET scan or an X-ray would help us to understand more, and more probing of neuropathic pain types, SLR test being done. How long is the pain radiating? Radiation of pain, quality of pain, and all would have been helpful. So definitely morphine has a role. Definitely palliative care has a role. For such a patient, if she is of normal weight and good RFT, LFT, given this age, I think I would start with 5 mg morphine first to see how she tolerates and then escalate to 10 mg morphine oral.
Sangeet,
And then
can we come out of this screen so that we can have, so that all of anyone, thank you.
yeah. So that is what I feel like. Ma'am, anything
Exactly.
you want to add?
No. Same. And I was also thinking mainly the first point is the important thing. Re-evaluate her, because he just remembered WHO ladder, re-evaluation in all aspects. And then total pain, physical, psychological, social, spiritual. Find out all 4 components. Then try to find out how are you going to deal with all 4. First, finding out is important. Only if you know what the problem is, you can treat the problem. See her, for example, I'm not the person judging. For her, physical component may be 20%. Her psychological and social component may be 80%. See, someone who cannot do anything is by herself. She will really feel that she is not needed. They may even feel, why on earth I should live when nobody wants me?
Yeah, for
Psychological, psychological, only one son. Okay,
antidepressant will help in such scenarios.
So that's what. So just like that, no, sometimes just the antidepressant, and then finding someone, some charity or someone who can help her, or finding some friend. That's what. Having separate discussion. So here, psychologist input may give you so much. Okay, so more better assessment. Then once you assess, treat each point in the best way possible. So it's more spending time for her, and then treating appropriately. Then comes radiotherapy. All you hit all the, don't leave any stone unturned. Correct all the correctables. Treat everything. So that is what. So that one. The 2, 3, and 4 will be covered. The 2, how to tell, what to tell. As I said, you have an entire session, 2 session on communication. Okay, so as I keep telling, we don't want to break all the secrets on day one. You all have to enjoy everything. So that, and then psychosocial issues, you have 1 session. For that also, you have an entire session. What is that? See, many times, many new things may come up. What you wouldn't have thought may come up on those sessions for you. So that is what is more important. And then there was something in the chat. No, I think this RT and that's what. So RT, DEXA, DEXA is a wonder drug. You will know more about DEXA even when we go for some other symptom also.
So DEXA can be given as OD. DEXA BD we do not prefer. DEXA is a long-acting drug. So
go ahead, Punitha. That single dose and what time is given also we follow, isn't it?
So better to give DEXA as a big dose in one single dose, either 16 mg OD or 24 mg OD. We can give IV in the morning time. Because it causes a lot of fluid retention and wakefulness. Insomnia is worse when you give it in the night.
Definitely. So that is again important. See, DEXA, if it is high dose IV, yes. Even if it is normal dose, like 8 milligram, you want to give, also give it as 1 dose in the morning.
Yeah.
Okay, because the insomnia and the side effects, what it causes are more harmful. Always risk-benefit ratio. Am I going to get more benefit by doing this? Please do that. Okay. So initially, at least sometimes 8 o'clock and 2 o'clock it was given. Nowadays, it is given as 1 dose morning. Best and better benefits have been obtained. So just stick to that. So those are things you have to keep, and which can be done that way, better to do it in that way. Okay, any other queries or anything like that? Anybody wants to ask, or please unmute and ask or anything. Otherwise, I think we have covered and done to what, because this case I didn't want to leave it, because something, even though the person who prepared couldn't come up due to technical issues, we thought it's appropriate. So I thought I will at least go ahead, read, and hope it was helpful for all of you.
Yeah. So the point that she's elderly and she's living alone is one significant thing we should remember when we are giving the dose of morphine. We can give a SR dose of morphine. Even I would see whether the tramadol has been properly dosed first of all, because that is the first thing we should do. When you see something, tramadol is not working, first we should see why tramadol is not working. Was it properly dosed? We should check. So it's not been mentioned, but that's what we should see first. Why tramadol did not?
No, these history are the clues for you. Okay, not working, because she may be not even taking. See, she's disinterested in life. Who knows that she's taking? Nobody is there. She might think, oh, I am not even, no one is to give me 1 cup of water, buy medicine. What will that
84-year-old, she will not know which is a pain medicine, first of all. No, madam, many
84-year-old may not know. All white color.
This pacha matra is for pain. So much of educating is involved in palliative. It will be sometimes you will learn to live with these people. Will know this is for pain. Do you remember? This is for pain. So and
we'll all become masters.
Ma'am, tramadol also 4 times daily is advised, no, ma'am?
Yes, 6 hourly. Yes, you can. I used to use it like that only. So even now I would say, like sometimes many times, you can give 6 hourly, 1 night you can give 2. If it is 50 milligram, go. See, max 400 milligrams. See, basics, keep your basics always right. Max is 400 milligrams per day. So I'm using 50 milligram tablets. 50, 50, 50, 100. So I've used only 250.
So many times tramadol, we do not escalate to the limit of 200 only. Then we will underuse tramadol and then think tramadol is not working and we'll go to
Correct. Everything appropriate. That paracetamol 1 gram QDS is the correct dose. But unfortunately, if you're a very small, see, again, no, you can't give 1 gram for a 35. You have to keep there where toxicity also comes. See, as I said, no, common sense. I think today's word is that for me.
Yeah.
That is very simple. And another 100 kilo patient, there also have to be careful.
Yeah, that's true.
You have both.
Yeah. So good. Any other experience sharing or any interesting cases if you want to ask, you can tell. Because 6:30 we'll wind up. Another 5 minutes more, no?
No, main thing, I'm so thankful, Punitha, you brought, this is what is needed. There are many things. See, you can do interventional pain. That is, yes, we can do anything and everything. You should know to put them to the right person. Okay, if you yourself can do intervention, very good, well and good, do. Or tell them that interventional option is there. Again, interventional option, possible. How much benefit it can give? It can give, it may not give. That again doesn't, because again, no, when it is a multifaceted pain, just one injection, 1 point may not give you the benefit. If it was a 1 point pain, it will give the benefit.
Yeah.
That's all.
That's true.
So picking up, so always the diagnosis. That
even in the intervention, we should not be very much in a hurry to do an intervention. Interventions will have failures, will have complications, may be short-lived effects. Even after radiofrequency ablation, 6 months later, patient will come with same pain. Maybe 1 year later, they might come with the same pain. It can happen.
And some simple medicine can do the trick also. Okay?
Yes, that's true.
Again, there's no failure in that. Oh, we tried everything. But then what we did, we just added morphine and paracetamol, and I added some neuropathic medication.
Yeah.
And this herpes zoster, no, again, is very, very important because PHN, post-herpetic neuralgia, is a very, very, very common thing. And elderly, 60, 70-year-old are more prone to get. If you treat that at the beginning, you give acyclovir, that is antiviral at the beginning. Any pain managed in the first stage very well will not go to bad post, like chronic pain. So everything is important.
Yeah, so in that medical knowledge management is very important. In herpes zoster, one thing we give all neuropathic pain medications, as ma'am told, antiviral is important. Now there is some lignocaine 5% patch which has come.
Yes.
So when we put it at the root level only, the whole dermatome pain will be, reduced. So you have to choose a place. You should find out which dermatome and put the lignocaine patch there. Instead of doing some intervention, that can be done.
See, only one point with lignocaine patches, 12 hours on, 12 hours off. Okay, that is very, very important. Again, lignocaine, very good. but all of you should know it's toxicity. Us being anesthetists, right, left, center, we use that. So that one is important. So anytime you all available now, you're going to use means max is 12 hours on, 12 hours off. Keep that in mind. Okay.
One iliac bone metastasis patient, I used to put one lignocaine patch only for positioning and all. We'll use lignocaine patch for on alternate days. They were like affordable patients, father of a radiologist. So he can't lie down on that side. One single point only pain. So for that reason, why to waste so much of morphine dose? He's already getting drowsy. So I had given lignocaine patch for that place only. As ma'am told, we'll put it on alternate days. 12 hours, we'll give the patch. After that, we'll remove the patch. One day we'll give free. With that only, he'll be okay. Many times, weekly, 1 or 2 patches only he would have used. He will manage for 2-3 days. So that...
See, that's what, so many things are there. So many patches are there. Diclofenac patch is available here, Punitha.
Yes, ma'am. New patch. It's called new patch, 100 mg.
See, that is again another thing. Again, you should be very careful. Someone has very high GI, all those things. That's all. Using it wisely and using it appropriately. One-off patch, one-off. This is bad. This is what I struggle. Use that time. Then take it off. Give rest. Go back and forth. I know they may be seeing you. You may be seeing them. In that way, your rapport and comfort with the patient will improve only. Sometimes, as I say, no, we should tell in the beginning itself that 0 by 10 may not be possible. We will be able, within the first few sessions, I will tell them whether they will come to terms if you tell that earlier rather than very late.
Very first time itself, we have to tell. Then they will they'll be very accepting in the first visit itself. At least sleep, if I get, that's enough. They will tell first visit. So that time itself, we should prime them that at up to 70 to 80% relief only I can give you. Then practically it will go. Otherwise, if you promise like every pain will be treated, it will not happen so easy.
See, assurance also, no, give realistic assurance. As I said, you will all have all that in your communication session. I don't want to, but that is what those words in. There are so many things, no. You see whether what you're all doing that, but use it correctly. No false reassurance.
Rouzan Pharma has come up with that 0.2 mg sublingual buprenorphine. That also, when you have no access to morphine, if you can read a bit about buprenorphine, how to use, because once upon a time I was not with any institution for palliative, so I did not have access to morphine. That time I was using buprenorphine only. So that is like oral tablet and then sublingually 0.2 mg. If you keep immediately, it will work.
That's all. It's the agonist-antagonist thing is what you have to remember in that. Okay, you would have had that in your morphine session. See, pentazocine, Olden 4-twin, and this, no, they are agonist-antagonists. So you have to be a bit careful with them. I have also used it. See, I've been from 1994, so I've worked in stages when nothing else was there.
Yeah.
Okay. When morphine was not freely available, I started, and then within 4-5 years, I had that.
Now, after using morphine, I feel morphine is a comfortable drug to use.
So this agonist-antagonist is what happens with buprenorphine and that pentazocine, which you have to be aware of. And then I think in your morphine session, that curve shifting, all that, they will taught.
The theory part of morphine will come. We should read a lot of theory about morphine, oral morphine, kinetics and dynamics. And then function should be definitely seen before writing morphine.
Okay. Thank you very much, Dr. Punitha. They all should have benefited from more cases and then practicalities. Thank you once again. And I pass it on to Sangeet to take over, please, now.
Thank you, ma'am. Thank you, Dr. Punithavathy, for the wonderful case presentation. Faculty presentations. Thank you, Dr. Radha, ma'am, for presenting the case and facilitating the sessions. Thank you so much, ma'am. Thank you, everyone, for attending the sessions. Thank you. Let's see you in the next sessions. Thank you. Bye.
Take care.
Thank you for your kind words and all the best to all of you.